He is an infectious disease specialist and an assistant professor of medicine at the McMaster University. He's also the medical director of infection control at St. Joseph's Healthcare. Please join me in welcoming Dr. Zain Chagla.
All right, thank you everyone, and thank you for inviting me to be here. It's a great opportunity to hear a multidisciplinary approach to this. And part of this presentation, unfortunately, I feel like I'm preaching to the choir here, because this is a group that's very engaged and very passionate about limb preservation, but really trying to go over a rational approach to testing diabetics, particularly looking for complications in their diabetic foot disease. So I have relationships, advisory board relationships with Abbott and Verity, who produce some antimicrobials that are not on the market, but I won't be talking about antimicrobials today. Okay, so we're going to talk about risk factors and incidence, and this is a common theme throughout the presentation. I think we went over some of this burden information at the beginning of these sessions, but just to go over, this is for diabetic foot ulcers in general, and this is actually data that came from my institution, but 27,000 cases, 16,000 hospitalizations, 32,700 days. These are astronomical numbers in our healthcare system. And in a time where we're talking about fiscal reform, the burden of this is just paramount in terms of just inpatient resources and not the outpatient productivity resources. 547 million in healthcare costs. This was again mentioned in this in the initial presentation when we were talking about data. And then this doesn't incorporate costs about secondary disability. This is just simply ISIS type data. And so about $21,000 to $50,000 Canadian dollars per clinical case. And so, I want to just contrast an example here. Cancer care for Canada is a $7.5 billion cost between chemotherapy and hospitalization. And, if you look at those numbers closely, it's about a 10-fold difference. But considering, if you go to a cancer conference or if you look at our cities and setups, even in Ontario, cancer centers are institutions of excellence everywhere. And, I'm inspired to hear about institutions of excellence within the province, across Canada, and down south. But the reality is those institutions of excellence are few and far between as compared to what we see for cancer care in Ontario and nationally. So I'm not going to belabor the pathology of diabetic foot disease, as I think this document has gone through. But the paramount feature here is when patients get infection and fully controlled diabetes is not only a vascular disease and neuropathic disease risk factor, but it is directly immunosuppressive on its own, which is a contributing feature to the development of diabetic foot ulceration and diabetic foot infections. The other part is the simple anatomy of the layers you have to go through to get a bony infection. And as we're talking about the investigation, particularly for osteomyelitis, the pathophysiology is as simple as the infection of bone from a tract going down to the bone. And often that is where we use our diagnostic testing to actually reveal whether or not patients have osteomyelitis. In terms of the microbiology, initial infections are typically gram-positive. These are colonization of the ulceration sites with the gram-positive bacteria that are around the site of infection. As ulceration and necrosis develop, you then get more gram-negative and anaerobic bacterium. And again, this is generalities. There are some settings, such as water exposure or nail injuries, where you do see direct extension of gram-negatives. And as infections get down to the bone, it's not a simple dynamic growth process. You do get different bacteria at different phases of growth. Some that form a biofilm, which are matrices of bacteria and proteins, and it creates difficulties with our treatment, both duration but also the drugs we use, in the sense that some of these infections are in latent phase. The bacteria aren't dividing. As you remember, beta-lactams are very active against actively dividing organisms. And so it does create some difficulties with our durations of treatment and the drugs we choose, as well as the penetration of those antimicrobials. So the most important part of diagnosing a diabetic foot infection is examining the foot. And as much as that seems like such a simple point, the number of referrals that I see on a given basis who people have jumped ahead and got to the diagnostic testing for the diabetic foot infection, but not done an adequate examination of the foot to see what is the level of infection, is it theoretical that this person could have a bony infection, and what is the duration and the appearance of the wound is quite high. And so that is my big thing. The classic signs of inflammation, these were defined by Pythagoras in 80-20, and they still apply today, so rubor, calor, dolor, tumor. There's obviously some caveats, so vascular disease may affect your calor and rubor to a point, but in the Wi-Fi system, we still see cellulitis and redness as a component. Neuropathic disease often does mask pain associated with diabetic foot ulcers, so pain on its own is not a slam dunk feature. It has to be associated with other things. And then eschars and membranes of the wound that require some level of debridement and examination down to the wound bed as the staging of that, and as well as the presence of purulence or anything under the wound is often masked by the eschar or membrane. Obviously, purulence, conjoint ischemia, which you talked about, foul odor, which is probably the poorest defining feature, surrounding cellulitis, which is part of the Wi-Fi system, and the duration of the wound is important in terms of both your investigations, your potential treatments, as well as outcomes in that sense. Step one of the diagnosis of a diabetic wound is, again, the physical examination as part of the history. So again, debriding and removing overlying tissue to really get an examination of the wound bed and the wound depth. Following the wound down to its bases, looking for tunneling as well, so doing an adequate probe, looking for undermining, making sure that there's no other definable method for the infection to track down to bone itself, expressing the purulence, and looking for any concomitant soft tissue inflammation or abscesses which may complicate treatment. We talked a bit about microbiology of these wounds. One of the major controversial areas is when to swab and what can you get from swabs. The Levine method, which is endorsed by Wounds Canada, involves cleaning off the wound, debriding non-viable tissue, and kind of getting to the deepest. If you're going to use a wound swab, use it at the deepest area of the deep wound. In a setting where I work, and I'm seeing folks who are sent to me with swabs and wounds, and I look at the wound, I throw out the swab information altogether because I don't have any good sense that someone has actually done this method for the wound itself. There's eschar, there's overlying membrane, so I can't really judge anything. And so when you do a wound swab, it gets sent to the lab. It typically gets set up on a number of media, the blood agar, McConkey, and chocolate. These look for staph, strep, Pseudomonas, and some coliforms. If you're sending swabs, they don't grow anaerobes, so if you're considering anaerobes as part of your therapy, which often is with necrotic and devitalized tissue, you're not going to find them on swabs. But I have to give you the caveat. What shows up on the plate is often something like this. So a bunch of different stuff. You can see some stuff that's kind of spreading, some stuff that's growing where the inoculum is, some stuff that's growing in some peripheral cultures, some stuff that's hidden underneath. And some of this can be recognized by just obvious visuals. So Staph aureus gives you very golden, large colonies. Streps, again, cause some hemolysis on the agar media. The coliforms have particular growth features too as well. They kind of spreading as a proteus typically. But in the workup of some of these organisms, you literally are plucking bacteria from the plate, putting them in automated analyzers. And so the lab, when it gets something like this, is really going to say, okay, is there anything critical in this wound that I need to speciate? Staph, streps, pseudomonases. For the most part, they will work those up and give you sensitivity patterns, but that's as much information as you'll probably get from a superficial swab. The rest of this stuff, to work up all of this would give you 10 different organisms, some of which probably aren't even pathogenic or responsible. So it's just important when you're sending off wound swabs, not to send them off to say, is this wound infected or not? But it's simply to say, do these have the critical staph, streps, and other organisms that you're worried about and need to define treatment for? So the next question is when to suspect osteomyelitis. And the general approach is, as everything in medicine, is a game of probabilities. So using diagnostic testing and using methodology for osteomyelitis is really defined on your pretest probability. If you have a low pretest probability, that being a wound that really theoretically probing the wound, looking at the wound and the location of the wound does not get anywhere near bone, it should not be worked up any further than immediate plain film and observation and treatment of the wound infection. Similarly, if you're seeing a wound that probes to bone, that is purulent, that is very classic for osteomyelitis, there's no need for diagnostic testing because you're wasting the system's money at that point. You know what the diagnosis is, and radiology, to confirm your diagnosis, is not going to help you do much more because the patient's going to receive treatment the same way. It's really in that middle ground where your pretest probability is 25 to 75%. There's a wound, it's fairly deep, it tunnels, I can't feel bone, but I'm not sure. There's a lot of overlying eschar. That's where diagnostic testing is going to help you make that determination and push you in one direction or the other. So the probe to bone test is a classically described piece. This is using a metal probe. I don't even know where I can find a metal probe on some of my wards these days. But you probe the deepest tract until that clunking feeling of bone. Often it's not obviously visible in that sense. There are a lot of studies that look at probe to bone tests, which have different results. The study I report here really looks at probe to bone as compared to bone biopsy, which is the test of choice, which was in that poll. But the sensitivity and specificities compared to bone biopsy are fairly good. If you look at positive predictive value, negative predictive value. And so this is just an example. If you're kind of sitting there in the 50-50 range and you do a probe to bone test and it's positive, you then increase your probability of this being osteo to about 91%. If it's negative, you decrease it to 13%. If you do that similar test in someone that I'm pretty sure doesn't have osteomyelitis, you're going to get a mixed result if you kind of feel bone, because that's not necessarily indicative of infection. And if it's really negative and you're doing a probe to bone, then it at least kind of gives you that more reassurance towards a negative value. Bone biopsy is the gold standard. This is described by Lipsky in the IDSA guidelines. But obviously there's some need for a setup for this. The tract usually needs to be exposed, especially if you're using a rongeur to actually get this. There are some other techniques using a jam sheet needle and image guiding techniques, so kind of getting a sample peripheral to the bone to hit a piece. This needs obvious expertise. It may not be obviously available. And again, there's some potential for catching colonized organisms in the wound tract while you're getting the bony piece. So it needs to be interpreted with caution. It often is very useful to send both culture and histopathology to take a look for the changes of osteomyelitis and then use the cultures to guide your treatment at that point, rather than just using culture-based techniques alone. Plain radiography is a cheap and easy tool. It's not particularly sensitive or specific, and it takes time for changes to occur. But in patients who are fairly reasonable risk, it's a good initial test because it's cheap and easy to do. So if you're catching changes of osteomyelitis on plain radiography, that's fine, and you move on after that. And serial plain radiography is actually a reasonable technique. So if you're going to treat this person for a prolonged amount of time, you're not sure if it's osteomyelitis or not, using serial radiography may pick up on those changes down the line, rather than some of these advanced diagnostic tests. MRI is the test of choice to use if you're unsure after X-ray. The reason being is the sensitivity is quite high, it distinguishes osteo, it picks up some of these secondary skin and soft tissue issues, and really in patients that are contraindicated, we should be using MRI. Bone and white blood cell scan are the alternate. This is really burdensome to patients. It costs about the same, and really, I think in Canada we tend to use this because of just the accessibility and availability. It requires 3 trips for a patient often to get a bone and white blood cell scan. So it's for a patient that's already marginalized, paying $20 a day 3 times for parking is sometimes unreasonable. It can be confounded by other changes, remodeling and Charcot changes, and really can be interpreted only in the area of the wound. And the number of referrals I get for folks who have a positive bone scan of a joint, 5 joints beside the joint that has the ulcer, and says this is osteomyelitis, is fairly impressive. So again, it has to be interpreted with the clinical context. Ultrasound and CT scan are pretty limited in their value. PET scan, which is fairly expensive, is becoming a fairly promising modality, as well as being able to use it as a test of cure, but price is really what's limiting. And then there's just the treat and see with serial radiographs. So in someone that's stable, that seems like they may have osteomyelitis, you're not sure, continuing treatment, looking radiographically and seeing clinical improvement is probably a reasonable strategy and fairly cost effective. So that's basically it. So I'll, for the sake of time, I'll move on, but be able to answer questions later on.